elaborating the cause for optic atrophy. Next, I call upon Dr. Thomas Arun Varghese for his talk on decoding the pupil. So he will elaborate how important it is to examine the pupil. We as ophthalmologists have the habit of seeing the patient after dilatation. So once we suspect neurological disease, we call the patient next day just to examine the pupil. So we'll see. Over to you, Doctor.
Thank you very much. So my next talk is decoding the pupil. So as you know, the size of the pupil is dependent on a balance between the ambient light, the sympathetic and the parasympathetic supply. The usual range is 3 to 4 millimeters, and you can have a physiological anisocoria, which apparently is there in about 15 to 20% of people. But a difference of more than 2 millimeters is considered significant. You know, sympathetic pathway, it's arising from the midbrain, going to the via the third nerve, ciliary ganglion, and then to the iris sphincter. So if you logically think you can have a problem anywhere along this, can cause a problem with the pupil reaction. And typically being the third nerve palsy, a tonic pupil, and uncal herniation. The sympathetic pathway arising from the brain, going down to the neck, and then upper chest, and then back up along the carotid artery. So you can test with the ciliospinal reflex, and the usual condition that we encounter is the Horner syndrome. Near response is the pathway that is, as you know, is quite complex, and it is important, especially in people where you do not get a good light response. Make sure you always check a near response. Ideally, you should be checking that in every case. So history, again, just like in any neurology, neuroophthalmology situation, history is very important. So history of blurring, amaurosis, transient double vision, all these are going to give you clues. Headache, numbness, again suggest of demyelination. Any history of trauma or surgery. Surgery, as you know, is a controlled trauma. So history of surgery of the neck, head and neck. Anything that, any history of like whiplash, all these are going to give you possible clues as to the etiology. And systemic diseases, diabetes, thyroid, neurological problems. And it's always very important to ask for a history of previous photographs. So somebody presenting with a condition, you examine, they present, say, for glasses, and then you see an anisocoria. So you can always ask them to bring any old photographs, what is known as the FAT scan or family album tomogram. And that can give you a clue as to whether it is a pre-existing condition or whether it is something new. Examination, visual acuity, color vision, of examination of the lids, as you know, third nerve and Horner's, obviously looking for things like that. Proptosis, extraocular movements, visual field by confrontation. Cranial nerves, a brief neurological examination, and of course supratemporal arteries. You know, as you know, in syringomyelia, you have involvement of the hands, so that you have a look at the hands. So all these are very important, not slightly different from your usual ophthalmology examination. And examine the neck for any scars. Examining the pupil per se, when you can gauge the size of the pupil. You can see my card is quite badly worn out. Anyway, the size of the pupil, the shape of the pupil, light reaction, near reflex, and swinging flashlight test. And important to remember, afferent pathway, an isolated afferent pathway problem does not cause an anisocoria. That is something we always need to keep in mind. So pupil, you see if it's the equal pupil size or anisocoria, and if equal, then you obviously check for an RAPD. Anisocoria, as I said, can be physiological, which can be differentiated, as I'll explain, and pathological. So it can be problem with the iris, sympathetic or parasympathetic pathway. So this you can see is a patient who had sustained a trauma. The video, the video, please. Video is not. Video? Okay. Anyway, here at sustained the trauma, you can see the subconscious hemorrhage in the right eye, and yeah. And just to illustrate the relative afferent pupillary defect, you can see the dilatation of the right eye. Okay. Next. Close. No, presentation. Thank you. So large pupil, think of a third nerve palsy, IDS pupil, or obviously can be a local cause, say post-surgery, post-trauma, and obviously think of pharmacological and systemic cause. Small pupil, you are mainly thinking of Horner's pupil, Argyll-Robertson pupil. It can be local cause like a uveitis. So anisocoria physiological, as I said, you need to identify, you can look at previous photograph, but the reactions will be normal. That's the main difference, and usually they are asymptomatic. This is a usual algorithm that you see in textbooks. So differentiate whether it's worse in dark or worse in light, the anisocoria, because as you know, a small pupil, if it's the abnormal one, then the anisocoria is going to worsen in darkness because it does not dilate, and the reverse in the case of if the abnormal pupil is the dilated one. But the usual one that I use is this one. So first, let's see the reaction, and you can see if both pupils are reacting. So for example, this lady, 41-year-old, presented with a headache, and you can see the anisocoria left pupil is larger. So what I usually do is see the reaction is how the reactions are. Light reaction is the larger pupil, and it's the poor reaction. That means the larger pupil is the abnormal one. And then look for other features, any ptosis, any extraocular movement formations, no. And then examine on the slit lamp, and you can see vermiform reaction. I'll show you the video in a minute. Now video, please. Sorry. Video. First one. This is just taken with the mobile phone, and you can see the vermiform. If you observe here very closely, you can see the vermiform movements quite clearly. There you can see very nicely the vermiform movements here. So it's just taken with the mobile phone with the slit lamp adapter, and so this will save a lot of trouble. But presentation. Thank you. So as you know, presentation. Thank you. But being in Kerala, as you know, patients are highly demanding, and the patient was presented with a headache. So as you know, typically in the case of AD's pupil, you don't need to go do further imaging. But in this case, she actually had imaging done because the family were extremely worried. And the MRI showed a tuft of vessels, and obviously then you have to go for further investigation. But she had the full investigation done, and everything was normal. Again, this is a third nerve palsy. You can see with the but this one was a pupil sparing third nerve palsy. While the next one, this was actually a post-op lady, and she was going back after a post-op checkup on a scooter with her daughter, and then unfortunately she fell off the scooter, and you can see she had a traumatic third nerve palsy with pupil involvement here. And she made again, you go by the same algorithm. You can see the poor reaction, larger pupil is the abnormal one, but she had associated features, ptosis, abnormal extraocular movements, and yes, that was the third nerve palsy, and she fortunately recovered. So going on to the small pupil, so if the reactions are normal, then you think that the smaller one is the abnormal one, and look for the other features, and you can see slightly smaller pupil there and a mild ptosis. And this was actually a patient who is actually a karate instructor, and then he came with some headache and some vague symptoms, and you could see the anisocoria, and he has also had a mild ptosis, and this was actually a carotid dissection causing the Horner syndrome. So Horner syndrome, I guess, obviously you usually go to differentiate all these, the peripheral versus central. You're mainly concerned about the peripheral ones because these are the ones that can not just cause a visual problem, but also can affect the life of the patient. So any history of neck surgery, neck trauma, also you investigate some situations. If you're really worried, you actually do an MRI, and you not just do an MRI of the brain, but you need to do an imaging right down to the neck. So that also has to be included. Obviously, if it is a long-standing Horner syndrome, you get a depigmentation, and the depigmentation as well with the Horner syndrome. That indicates that it's a long-standing and not something you need to be worried about. But it's the peripheral one that you really should be careful about, because you should not forget that we are usually used to imaging MRI brain, but in this situation you have to do MRI imaging down to the neck, and that should not be missed. Light near dissociation, mainly Argyll-Robertson pupil. That is, you can do the smaller pupil. Light reaction is absent, and near reflection reaction is present. You usually talk of the aberrant regeneration of the third nerve, which also can cause an anisocoria. This is actually a patient with a third nerve. You can see that has recovered, and when the patient is looking to the right, you actually see a meiosis. So this is one of the other features of aberrant regeneration of third nerve. You can get a synkinetic meiosis as well, in addition to the lid retraction, which you can see here quite nicely. So take-home message: pupil examination should be an integral part of your examination. And if, as the chair mentioned, if you dilate the patient, just bring the patient back another day and check the pupil reactions again. And use a stepwise method. A careful history will give you important clues to the possible etiology. Thank you.
Thank you, Dr. Thomas. Next topic is diplopia demystified. The topic usually supposed to be done by Dr. Neena, as she is not here. Dr. Kalemedi will cover up that topic.